Hi, today my topic is RH incompatibility during pregnancy. This incompatibility occurs when the mother has RH negative blood group and the fetus has RH positive blood group. RH factor is nothing but the D antigen. If this antigen is present on the surface of red blood cells, then the blood group will be RH positive. And if this antigen is not present on the surface of red blood cells, then the blood group is RH negative. I will discuss this incompatibility in two scenarios: when the patient is primigravida and when the patient is multigravida. So when the patient comes with Rh negative blood group during antenatal care, the first test is to do the husband's blood group. And if husband's blood group is Rh negative, then all babies will have Rh negative blood group, and there will not be any problem because mother has Rh negative blood group and baby has Rh negative blood group. But if the husband has Rh positive blood group, then ask for the zygosity. And if the husband is homozygous, then all babies will have Rh positive blood group. And counsel the couple at this time that all pregnancies will have to be carefully evaluated because of this Rh problem. And if the husband is heterozygous, then there are 50% chances that the baby will be Rh positive and 50% chances that the baby is Rh negative. Now the next test is to do the Rh antibody test of the patient by indirect home test. And this test is a qualitative test. In primigravida, this test is negative because the number of beta red cells which enter into the maternal circulation are very few and cannot initiate the antibody production. So the stimulus is very weak and antibodies will not form. So this Rh antibody test is negative in primigravida. There is only one exception: if the patient has previous positive blood group transfusion during emergency situations like surgery or after road traffic accident, then this test will be positive. Otherwise, this test is negative in primigravida. Then repeat the test at 28 weeks and 36 weeks. So, and this test will remain negative. And the baby will not have any problem during pregnancy or even after delivery. And baby should be delivered by normal obstetrical management. Mixing of blood occur during or after placental separation. And by the time baby is already delivered, so during placental separation, a large number of fetal cells enter into the maternal circulation and will induce antibody production, and which but at the same time, if anti-D injection is given, which has preformed antibodies, so these preformed antibody will neutralize the fetal red cells, and mother will not be sensitized, so there will be less damage or no damage during subsequent pregnancy. And once the baby is born, cord blood test is done to see the hemoglobin level, blood group of the baby, bilirubin level, and the antibody titer by a direct home test. If the baby has Rh positive blood group, then the mother is given anti-D injection within 72 hours of delivery. Here, I just want to add one more thing. If there is any bleeding episode during pregnancy, like threatened abortion or antepartum hemorrhage, or if there is any procedure done like in which fetal red cell may enter into the maternal circulation, like chorionic villus sampling. So in these situations, also anti-D injection is given because to stop the antibody production, because fetal red cell will be covered by preformed antibodies and mother will not be sensitized. So there will not be any damage to the baby during pregnancy. Now come to the multigravida. If the patient is multigravida, then Rh antibody test will be positive because uh, since multigravida has previous babies, so because of positive Rh positive blood group baby uh, patient has, this antibody test is positive. So after like the multigravida comes to antenatal care, the first test similar like husband's blood group and zygosity, and after that our Rh antibody test, and this test is positive in multigravida because of previous Rh positive babies. And then to see the level of antibodies, titer is done, how and which is done by direct home test. And if this titer is high, then repeat this antibody titer every 2 to 4 weeks. And it is better to do every 2 weeks. If the results show that the antibody level is rising, then it means the baby is affected or will be affected. So the hemolytic, since antibodies are high in number, they will enter into the fetal circulation and will cause the damage of fetal red cells. So hemolytic anemia occur, and then hepatosplenomegaly and erythroblastosis fetalis may occur. And this condition may progress to the hydros fetalis, in which fluid accumulate into the body cavities and fetus can die inside the uterus, so intrauterine death may occur. To, that's why to see how much baby is affected, repeated tests are advised. So the repeated ultrasound should be done with middle cerebral artery. Doppler is done to see the fetal hemolysis and fetal hypoxia. If middle cerebral artery Doppler shows that the baby is in severe distress, then the chordosynthesis is advised. And the blood is collected from the umbilical cord near to the placental attachment. And four things are checked: hemoglobin, blood group, bilirubin level, and the antibody titer. If these two tests shows that the baby is badly affected, then the baby is treated with intrauterine blood transfusion. Intrauterine blood transfusion. And this transfusion is started at 24 weeks of gestation and repeat every 2 weeks until the baby reach to a certain level of maturity, like around 32 to 34 weeks, when baby can survive outside of the uterine cavity and should be delivered by cesarean section. Since this baby is acidotic and cannot uh, bear the painful uterine contractions of labor, so should be delivered by cesarean section. Once the baby is delivered, cord blood test is done on the baby to see all four tests: hemoglobin, blood group, bilirubin level, and the antibody titer. And depending upon the results, baby is treated either by the phototherapy. If there is not severe hemolysis, then phototherapy and simple blood transfusion. And if there is severe hemolysis, then the exchange transfusion is done. And uh, once the baby is delivered, mother is given anti-D injection within 72 hours of delivery. I just want to add one more thing. If the father is positive and mother is negative, then there are 17% chances that the baby will be affected. And if anti-D injection given after delivery, then the failure of anti-D injection treatment is 1% to 2%. And if this injection is given within during pregnancy, like around 28 weeks, then the failure of anti-D injection treatment will reduce to 0.1%. Hope you understand the RH incompatibility during pregnancy. If you have any question or concern, I will be happy to help you or answer those concerns. Thank you very much. Have a nice